My first discussion will be for the guidelines regarding PCNL. Okay, the guideline recommendations about the percutaneous nephrolithotripsy are more or less clear in which cases the procedure is going to be performed. But before we go exactly at the guidelines, and of course the guidelines are always recommendations, and it's up to our decision to which procedure we are going to do for our patient, which is best for our case that we have at hand. I would just present you what are the indications for active removal of a renal stone according to the guidelines. You can see that it's a whole list of indications. I would say that most of the times the indications that we are going to consider most are the indications that are related to complications for the patient, and sometimes can be even the wish of the patient to be over with a stone that is in his renal system. The recommendations of the guidelines practically set PCNL, the percutaneous nephrolithotomy, as the first approach to manage any stones that they are more than 2 centimeters in size. So every stone that is in the kidney and is more than 2 centimeters could be treated with percutaneous nephrolithotripsy as the first approach, and all the other approaches, shockwave lithotripsy or retrograde intrarenal surgery, ureteroscopy, are a second approach. Stones that are 1 to 2 centimeters could be treated with shockwave or endourology, and stones that are less than 10 millimeters, in this case, the PCNL is considered to be a second option. That must be a very specific stone, a very specific case that we are going to do PCNL for this kind of stones. A special special type of stone are the stones that they are located in the lower pole of the kidney, and they have a size between 1 and 2 centimeters. These stones may have some unfavorable factors in order to be treated with shockwave lithotripsy. Probably, according to what we previously saw, we are going to treat these stones with shockwave lithotripsy. But if there is an unfavorable factor, and these factors are the steep infundibular pelvic angle, the long calyx, a long skin to stone distance, the narrow infundibulum, and maybe a stone that we have already done a shockwave and has not been treated. In these cases, we are going to manage the stone with a different approach, and that would be, according to the guidelines, endourology. And when we refer to endourology in the guidelines, we refer to both PCNL and ureteroscopy. So these are more or less the indications that they are recommended by the guidelines. So PCNL, the first treatment choice for stones more than 2 centimeters, shockwave and endourology for stones that are less than 2 centimeters, and if we have lower pole stones with unfavorable factors, we are going to try not shockwave as the first option, but endourology, either PCNL or retrograde intrarenal surgery. When we refer to PCNL, we have the so-called standard PCNL, which is 24 to 30 French, and we also have the mini PCNL, which is less than 18 French. This is what the guidelines say, but in another point inside the text of the guidelines, they define as mini PCNL cases that they are less than 22. PCNL that we do with instruments and see that they're less than 22 French. More or less, this means that this reflects this difference in how this specific mini PCNL cases are being defined by the guidelines, reflects the clinical practice and the problem that we have in the literature, that practically we do not know exactly what is mini PCNL, which are specific. We do not have a specific definition what is mini in comparison to the standard. Anyway, what we have to must have always in mind is also not only the indications of PCNL, but also the contraindications. And the contraindications, you can see them clearly: patients on anticoagulants, untreated UTIs, tumor in the presentive tract to do the PCNL, a potential malignant kidney tumor, and pregnancy. These are the contraindications. So more or less up to now we have discussed about the indications, contraindications, and of course a minor issue in the literature related to the size and the proper definition of the mini PCNL. But what could be, if we decide to do PCNL, what would be the best practice according to the recommendations of the guidelines? And for the lithotripsy, the guidelines more or less are the guidelines, but in general practice, what we know about doing PCNL is that in rigid nephroscopy, we can use the ultrasound, we can use the pneumatic lithotripsy, and of course, some of us, depending if you are doing mini, we can also use the laser. But in mini instruments and in flexible nephroscopy, in this case, we always use only the laser. We have different sources. I hope that the videos are going to start working. I don't see them working at all. Okay. It will take some time.
No, it's okay.
Yeah. All these sources are considered to be acceptable. I'm glad that you see them, because I don't see them here working. All these sources are acceptable by the guidelines to use the laser or the pneumatic or the ultrasound lithotripsy. And of course, I hope that anyway, as you can see, we also I'm also presenting you here that it was supposed to be showing a lithotripsy, a laser lithotripsy, but another recommendation. So all the energy sources that we saw, laser, pneumatic lithotripsy, and ultrasound, are acceptable according to the guidelines. When we are going to prepare our patient for doing a PCNL, in this case, we'll have to do an ultrasound or a CT scan, but the best recommendation according to the guidelines is to do a CT scan with contrast medium. We have to do it practically in all patients in order to understand the anatomy, in order to know where our stone exactly is and what will be the surrounding organs, so that we can avoid injuries like the one that you saw in the CT scan, that the nephrostomy passed through the liver. Patient positioning. When of course we have prepared our patient and we're ready to go for doing the PCNL. Does it matter? Does it matter to do it in prone, or does it matter to do it in supine? There are advantages and disadvantages for these two approaches. We must know both of them. We must know which advantage will be for the patient if we do prone or if we do supine. And practically, the guidelines propose that in our practice, these approaches are both equally safe, and there is no specific advantage of this regarding the stone-free rate and the operating time. It's so more or less, if we are going to choose the one approach in comparison to the other, is mostly based to our experience and to the case that we have. But it's always better to know both approaches. Sometimes can help us out in specific cases. How we are going to do the puncture after we place the patient. There is no specific recommendation, but there are some suggestions, some points specific point out by the guidelines, like the fluoroscopy is the most common, is one of the most common intraoperative imaging methods that we have, and we can see it real time. We don't have to use it, and we don't have to use any fluoroscopy, any radiation exposure. We don't have at all when we do this kind of surgery. And at the same time, we can see also the surrounding tissue. So ultrasonography, although it cannot be proven that it's better than doing a fluoroscopy-only puncture, it's being discussed in the guidelines. Dilation methods, how we are going to dilate the tract. Practically, there is no specific recommendation. All dilators are acceptable. A single-step dilation is considered also to be equally effective to a multi-step dilation. And all the results that we have in the literature, all the evidence that we have, are based on the experience of the surgeon, rather than that the method is better than the other. We cannot really tell. Which instruments we are going to use? There is the standard PCNL and there is the mini PCNL. Of course, we can go for a mini PCNL if we decide in a case. But are we going to have any advantages of this? And what the guidelines say is that it can be done, mini PCNL can be done, and tends to be associated with significant lower blood loss. But the duration of the procedure is significantly longer. This means that practically when we do PCNL, according to the evidence that we have, we don't have a clear advantage of mini PCNL in comparison to the blood loss. And we don't know that this approach has a disadvantage in comparison to the standard PCNL regarding the operative time. And why is that? Because practically we don't have very good quality evidence comparing the two approaches. So we see a tendency, but it's not clear if the one approach has an advantage over the other. When we are going to place, after we are over with the procedure, where we are going to place a nephrostomy or a stent, usually the traditional approach, I would say, is that we are going to place a nephrostomy with trying to find out by having a way to tamponate the bleeding of the tract, to drain the urinary tract in case of obstruction, and to allow an easier access if we want to go for a second loop procedure. That's why we place all these drains. But the last few years, there has been an effort to reduce the use of these drains in order to improve the comfort of the patient. So we have the tubeless and the totally tubeless PCNL. And tubeless PCNL practically means that we are not going to place a nephrostomy, but we are going to leave a double J inside the patient. Totally tubeless means that we are not going to leave any tube at all in the patient. So what would be the benefit? It would be less postoperative pain, less analgesia requirements, and less length of hospital stay. But the truth is that these cases should be done in really uncomplicated cases that everything went very well, we don't have any bleeding, we don't have any residual stone, we don't have any other issues like UTIs that may be related to these stones. So this is, I would say, a bit uncommon to have all these cases, especially if you treat stones that they are big. So how you are going to decide, according to the guidelines, if you are going to do a tubeless procedure. And this is the list of the possible cases that you have to leave a draining tube. So either you must, if you have residual stones, if you are going to do a second loop procedure to manage these residual stones, if you have significant intraoperative bleeding, if you have ureteral obstruction or urine extravasation, or potential persistent bacteriuria due to the infected stones, or a solitary kidney, or bleeding diathesis, or you are planning to do a percutaneous chemolysis. And in all these cases, you are going to leave a draining tube. But what the guidelines say with a strong recommendation is that in uncomplicated cases, you can perform tubeless without leaving a nephrostomy tube, but leaving a double J inside the patient in order to, after you are over with your PCNL procedure. Some minor points that are also interesting in the guidelines is that we must have in mind that the PCNL is a high risk for bleeding procedure. So if we have a patient that may have risk for thrombotic or bleeding diathesis, in these cases we have an asymptomatic stones. In these cases we just don't perform PCNL, and we should probably go for active surveillance. Of course, we can temporarily discontinue antithrombotic therapy to high-risk patients in order to do PCNL if it's necessary. And of course, we can use PCNL in order to remove stones with special anatomy, special cases like cases with calcial diverticulum or horseshoe kidneys, or stones in pelvic kidneys, or stones formed in continent pouches, or in patients with obstruction of the UPJ. You can also perform PCNL and make the patient stone-free. Also in children, and the stone-free rates are directly comparable to the adults, and also the indications for PCNL in children are the same. Usually, because shockwave lithotripsy is very effective in the case of children, if we're going to do PCNL, we are going to do it in cases that we have stones more than 2 centimeters in the renal system for children. This was a summary of the guidelines. I hope that it was not tiring, but always the guidelines are a bit more strict, and there are specific points that we can discuss on them. So if you have any questions, I'll be happy to hear them.